Well, may highlight talk about the use of play as a method in doing research. I would probably talk about how we utilize play and good old fashioned ethnographic research using participant observation in pursuing one of the themes, one of the data that we generated from play, which is shame. So I'll be talking about shame. Let me begin. And let me read. In the living room of a Waray speaking family of a remote fishing island barangay in northern Samar, where I stayed during fieldwork, sits a collection of DVD featuring Zumba, a globally popular dance exercise being promoted by the Philippine government, academic, and non-government health organizations, along with media stars to instill the idea of healthy living. Zumba serves, oh, it's not screen. Sorry. Zumba serves as one of the highlights of Northern Samar public fun runs, referred elsewhere as marathons. This fits in with the international discourse where emphasis is put on the individual to take responsibility in taking care of one's own health through the promotion of ideal lifestyle. Such discourse has led to healthism, the preoccupation with personal health where people monitor every detail of how they live their lives and how this may affect their health. Healthism is a form of medicalization where health becomes a super value and it situates health at the level of the individual. Sociologists link healthism to moral panic in our society. Indeed, the optimal healthy lifestyle is contrasted against an unhealthy lifestyle that carries risk with it. Sociologist Ulrich Beck wrote about the contemporary world that is increasingly becoming a risk conscious global society, of which the idea of monitoring and avoiding risk have become part of the givens of everyday life. These courses of healthy living embeds the categories of the optimal and the perilous. It indicated how people should behave. Good behavior will keep people healthy, and bad behavior will make them sick. That discourse of risk is in turn reinforced with medicalized protocols of well being promoted by international health bodies such as the World Health Organization and advocated by non governmental health organizations worldwide. Let me give you an example of a public health campaign from the Philippine Department of Health, where the message is underscored by such lifestyle discourse that points out how individuals exposes oneself to risk. This quote comes from Healthbit, a government-published health magazine. The best way to stay healthy and avoid most diseases is to adopt a healthy lifestyle by doing physical activity or exercise, eating the right kind and amount of food, no smoking, responsible drinking, and having a regular medical checkup. To promote this position, Philippine health officials summoned up the power of pop culture by appropriating the American television reality show Biggest Losers in recognizing the top 10 government health executives who lost the greatest amount of weight after going through a battery of exercises. Not living up to such an optimal lifestyle supposedly exposes a person to the risk of illnesses which are articulated with a biting sense of humor and embarrassment in the Department of Health's popular publication. Jokes shaming men, but especially women, for not watching the weight are turned into the business of government. I'm the business of government. You can see that in my weight. Lechon, that you can see in the picture, originally a traditional Spanish pork dish, is one of the Philippines' most popular dishes. A delectable, slow-roasted suckling pig, usually served during fiestas or celebrations. This global discourse of healthy lifestyle is well established in Philippine popular and government imagination of healthy living, effectively placing the onus of healthy living on the hands of the individual. But what happens if we extend the notion of lifestyle and health risk through the lives of struggling northern summer families that could hardly afford 2 square meals a day? What if we consider an overburdened mother who could hardly wash properly, feed nutritiously, and therefore expose her children to fatal but perfectly preventable illness? What if we apply The idea of lifestyle and health risk to an overly stressed wage earning couple who look forward to pleasurable sex rather than think about birth spacing or pregnancy rest period. What if we view lifestyle and health risk in the hard knock lives of an impoverished family that keep a mentally ill relative on a tight leash at home rather than seek healthcare because high medical costs and stigma prevents them from doing so? What if we view lifestyle and health risk in a locality where the sense of old Spanish and American paternalism continues to reflect the manner by which powerful political clans rule what were once colonial villages and towns, such as the Solas field sites in northern Samar? In such contexts, lifestyle becomes less of a choice but more of a calculation of the chances of the marginalized in dealing with what medical anthropologist Nancy Shepard Hughes called the destructive signature of poverty. In her book, Death Without Weeping, she uses ethnographic data she collected in Brazilian shantytowns. Her ethnography points exactly to the many instances by which poverty ravages and also prompts people to confront it with, as Shepard Hughes coins it, their wits intact. The capacity and ability of living a healthy life cannot simply be regarded as a given. In many ways, health is implicated by broader social forces shaped by specific relations of power emerging from historical processes and circumstances. Viewed from the lenses of Samar and Waray sociopolitical relations, lifestyle does not necessarily reflect the ideals of healthy living, but rather manifests the marker of inequalities that persists throughout the country's post-colonial experience. We turn to Paul Farmer, an anthropologist, clinician, who is one of the most influential advocates for health equity and whose work is rooted in both social science and medicine. Central to his work is the concept of structural violence. I quote, social arrangements that put individuals and populations in harm's way. The arrangements are structural because they are embedded in the political and economic organization of our social world. They are violent because they cause injury to people. In extreme social economic circumstances and political marginalization, who then must sit to stew and serve as a better arbiter of the binary notions of good and bad or risky lifestyle? Does the contemporary lifestyle discourse offer a useful frame in adequately understanding healthy living? Or is it perhaps an elitist and ethnocentric way to think about what is healthy, hopelessly detached from the hardness of the conditions of life in impoverished communities such as those in northern Samar? This presentation, which actually I have written with Lisa, caution against marking individual lifestyle as the sole framework in understanding well-being without taking into account the social and cultural determinants of health. This is not to say that the concept of lifestyle is not valid at all, but in interpreting the data we collected in Northern Samar, we need to take into consideration the complex set of values that continue to resonate with the rise of today against the backdrop of health inequality. The entanglement of health and equality issues into the structures and deeply held cultural values of a society, implicate the question of healthcare. One of these complicating values is the notion of shame, a consequence that the Philippine Health Department seemed to make in unleashing those sardonic sense of humor in its public health campaigns. Shame is in fact a classic subject widely examined in the anthropology of the Philippines. This array of ethnographic work suggests that shame is a widely shared sociocultural value in the country. Coincidentally and inevitably, the idiosyncrasies of shame implicate access to health care and the health care of the impoverished Waray fishing and farming communities of northern Samar, one of the poorest and sharply inequitable regions of the Philippines. The Waray notion of shame is encapsulated in the term alo, which invariably meant being shy, timid, bashful, embarrassed, and ashamed. This emerged in our conversation with barangay health workers, fishermen, and their respective families about health access. Shame also manifested heavily in non-health contexts, but that is beyond the scope of this presentation. Shame is a deeply and widely held value with implications to healthcare when we consider public health promotion of healthy living and health interventions. This is especially pertinent in the Philippines now that the country's illness profile is consistent with a double burden of disease. Communicable diseases continue to be a major cause of morbidity and mortality, but now in combination with the rising prevalence of a non-communicable diseases and a consistently high fertility rate. The consequential implications on health became evident to us during our fieldwork among the health workers. Berna, a BHW, a barangay health worker, on one of the island Solas barangays, pointed this out to her fellow BHWs in my presence while walking down a path across the home of the Rosario family. After exchanging pleasantries with a middle-aged woman named Rosa, Berna hurriedly came back to us, lamenting how difficult it was to convince Rosa to take her teenage daughter, Rina, to the rural health unit for a checkup. Berna knew Rosa and Rina well because Berna herself lived in the community and had been a BHW serving this household for a long time. Berna said she had heard from neighbors and Rosa's other relatives that her daughter was pregnant but without a husband. Berna told us that the family may have felt deeply ashamed of the circumstances of the pregnancy, dissuading them to seek clinical care. As a result, the BHW could not offer proper prenatal examination for a pregnant teenage girl. During my fieldwork, I further learned about the potency of shame in shaping health decisions, and in disinclining locals to seek medical care from the formal health sector. The sense of shame kept several other families from reporting pregnancy issues, including cases of married mothers with several unplanned pregnancies and those bearing a child in their 40s. Families of unmarried pregnant women, whether teenagers or adults, feel being scoffed upon amid the dominance of sacredly held Catholic religious values of having a child out of wedlock. One woman recounted how a pregnant member of her family endured the indignity of being scolded at by a doctor in paternalistic fashion, supposedly for being unable to control her sexual urge, expressed in Tagalog as matanda na, naglalandi pa, slutty old hag. Mental health is also viewed to be best kept as a family secret, less because of its repercussions to the family's collective honor, but they simply could not pay for mental health interventions. As a result, the mentally ill are kept at home and in some cases tethered to a post when they hurt themselves or other family members. HIV, which is now prevalent in the wider Eastern Visayas region, is a health concern that cannot be discussed openly. Not only because of HIV-associated stigma, which is well documented in the literature, but also by the interlocking but clashing values of religious morality, indigenous sense of shame, and paternalistic, often problematic doctor-patient relationships. Many Waray shared that they choose not to seek formal healthcare, overwhelmed by the anxiety of exposing themselves and their families to shame. In Samar, shame lies deep within Waray values, which predates modern health relations. Sense of shame keeps them away from what they see as the intimidating glare of clinicians, which in turn renders their health conditions invisible and healthcare underserved. Anxieties and the sense of shame besetting the Waray rural poor expose the chasms underpinning the relations between the impoverished citizen and the provincial health delivery system. A closer view of these chasms reveals that the implication of post-colonial history. The Waray region of Samar sits at the lower end of the national development, poverty, and health measures, even as the standard of living in other regions of the country, except for the conflict areas of Mindanao, began advancing in the past 2 decades. Samar, however, had been consistently relegated to the back end in the wider history of national socio-economic progress since the country sets down to take the path of democratic modernity following the end of colonialism. Writing from a post-colonial standpoint, historian Dipesh Chakrabarty points to ambivalences, contradictions, the use of force, tragedies, and ironies of a post-colonial democratic state and its instrumentalities. Chakrabarty argues that nowhere in this irony, and I quote, more visible than in the history of modern medicine, public health, and personal hygiene, the discourses of which have been central in locating the body of the modern at the intersection of the health and the private, as defined by and subject to negotiations with the state. End quote. When viewed from a post colonial analytical frame, it becomes evident that health related shame is manifesting under a healthcare system burdened by a body politic that historically relegated ordinary waray into a position of marginality. Far from a peculiar waray experience, variations of shame such as stigma and discrimination are also holding back marginalized constituencies in manifold settings, including medically advanced industrialized nations and struggling developing world, from seeking adequate care. Shame and its variations form part of the social determinants of health. These values deserve harder scrutiny as they reproduce with fatal consequences in an age dominated by the globalizing discourse of healthy living that draw attention to lifestyle risk and primary health care responsibility to individuals decoupled from the broader structures of inequality underpinning local healthcare experiences. Thank you very much.